climate change and antibiotic resistance are two eminent threats to humankind. In Lancet, the study was published, and it shows that in 2009, 5 million deaths were attributed to antibiotic resistance. And the death due to COVID in 3 years was 6.9 million reported death. And it is 3 years. And the antibiotic resistance death is in the 1 year. So the antibiotic resistance is far more worse endemic than COVID. This is ICMR data. They analyzed 1 lakh sample in 2029, and they found that Envenom, carbapenem are E. coli resistant to carbapenem in 64% cases. And similarly, that Klebsiella pneumonia also, only 43% Klebsiella pneumonia samples are sensitive to the carbapenem. So resistance to carbapenem in Acinetobacter baumannii was recorded to 87.5% in the year 2021. In around the world, the main organism that are causing death is escape. That is E. coli, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Enterococcus. But in India, again ICMR study, it shows the mainly it is a pigs organisms, that is Pseudomonas, E. coli, Acinetobacter baumannii, Klebsiella, and Staphylococcus. We all know that main resistance mechanism or carbapenem resistance are three types: enzyme productions, porine mutation, and efflux pump. And out of this, enzyme production is much more important. And again, we can divide carbapenem resistance as per the carbapenemase producing resistance and non-carbapenemase producing organisms. And again, we do a classification that is called, we all know, is Amler classifications. And where there are and out of that, OXA 48 is common all around the world. But in India, it is a New Delhi metallobacter lactamase. Sir, I want to ask you, in some lab, they do carbapenemase tests, and some lab they don't. So my query is that, sir, should we do regularly carbapenemase testing?
Yeah. So I have just a moment. Sandeep, I have sent the slides to your WhatsApp number. Okay.
Yes. So we will add it.
So right now we can start, as Dr. Saurabh already discussed about there is a growing problem of different Enterobacteriaceae, as well as some of the other organisms in the non-Enterobacteriaceae group. There are concern about the multiple drug resistant organisms. So about the carbapenemase producers, so there is a concern. Question is whether we should test the carbapenemase or not. So as the previous slide, Dr. Sandeep, Dr. Saurabh has shown that there are different type of the ESBL, or sometimes we call them different type of the resistance pattern that can happen. So in that resistance pattern, you will see there are carbapenem means basically carbapenem resistant organism. So if the carbapenem resistant organisms are there, if you want to make a kind of conceptualization about the concept. So one is carbapenem resistance. There are different type of the mechanism against that carbapenem resistance. And in that scenario, there is a concern whether any particular organism from Enterobacteriaceae is resistant to carbapenemase, resistant in the way by producing carbapenemase or not. So carbapenemase is one enzyme that actually hydrolyzes the carbapenems. So if there is only carbapenem resistance, so it means there are other mechanisms also other than carbapenemases. So if the organism is particularly carbapenemase producer, then there is a concern you should not use any of the carbapenems. But if otherwise, if just there is a report that it is carbapenem resistance, then by giving a higher dose or sometimes by giving a prolonged infusion, you can combat that pattern of the resistance or carbapenem resistance. And in that scenario, you should know there is defined terminology used, that is the MIC breakpoint. So if you continue to give a higher dose of any antibiotic, sometimes you can break that antibiotic resistance. So in the same way, basically for the carbapenem resistance, you are giving a higher prolonged infusion. So that is the way we should know what is the carbapenem producers or not. And second thing, if producer, then what particular genotyping is there. That is also important, because some of the particular genotypes, as Saurabh has mentioned in a series, there are metallo-beta-lactamases. So if the organism is beta-lactamase is producer, so then definitely the newer beta-lactam or beta-lactamase combinations, like in our country it may not be available, but in other country it is available, like meropenem, verobactam, or imipenem, silasting, relivectam. Those should not be used. So in a short way, you should know whether carbapenem producers are there or not, and even the most of the laboratories are not doing, but it should be done. And second thing, what is the exact pattern or mechanism of the genotypic and phenotypic variants of that particular carbapenem producers? Okay, that is very important.
So, sir, I think it is also help you to choose a antibiotic. If there is NDM producer, then we have to add astronam along with zebizeptam.
That I
And
just that time it will the newer beta-lactamase inhibitor will not work.
yes, the India, it's, I think I don't know about meropenem, relivectam, but we are using zebizeptam now, and it's also out of patent now. So, like in that way, if there is NDM producer, we should use astronam, and if it's not NDM producer, I think we can use only zebizeptam.
Yeah. So, and then there is also, if we are discussing in that line, there is also a concern about the, sometimes we use the your ceftazidime avibactam combination for some of the metallo-beta-lactamase producers. And there are certain metallo-beta-lactamase producers that you can also add the actually aztreonam.
Yes.
To make it more scientific, there is the synergy test. Because that synergy test is that in some way, in some cases, you may use only the ceftazidime avibactam. In some cases, you may use the ceftazidime avibactam plus aztreonam. So we want to get the aztreonam plus avibactam, that synergy. So without doing that synergy test, we cannot say simply that it will work. Okay, because if we, for example, if you see two organisms, say Klebsiella pneumonia and E. coli, the synergy test means basically you in E. coli, you must do the synergy test. Without that, there is a high chance, almost 60 to 80% chance is there, this synergy may not happen. So in spite of the same, your carbapenem producer as well as some metallo-beta-lactamase producers probably, so it may not work. Okay, but if the synergy test is for the Klebsiella pneumonia, most of the cases the synergy test will be in vitro as well as empirically also you can give, because usually that works. So for the organism like Klebsiella pneumonia, you can give ceftazidime avibactam plus aztreonam without doing synergy test, or if it is not available. But for the case of E. coli, you must do the synergy test. Okay, without that, ideally it should not be given because it may not work in majority of the cases.
Sir, for the students here, can we simplify it and simplify it in a manner that everybody can understand? Say, suppose I get E. coli in my antibiogram, which is showing resistance to meropenem and imipenem. What is the next thing we should do? And what are the tests which are available to show you the kind of resistance that this bug may be having? I mean, what are the commonly available tests? What is the taught time and how it is going to help us? Molecular diagnostics.
Okay, so can you just share that slide? Okay, whatever, there is a good slide about the one slide about the resistance pattern. Okay, suppose this one. So suppose you can consider a case, okay, like this 51 years old man was admitted with ARDS. He was being ventilated for the last 10 days and he was having fever, left sided opacity in the X-ray, ET secretion is showing that there is Klebsiella pneumoniae. Okay, and in your sensitivity pattern, there is a resistance of practically all antibiotics, except they have reported that this is sensitive to chloramphenicol, TG-cycline, and it is intermediate to colistin. Right now, there is a question that how do you interpret this intermediate to colistin? So, coming back to this year, your question also. So here is a concern if there is resistance to all except, means basically this organism Klebsiella pneumoniae is resistant to the practically most of the cephalosporin, your penicillin, cephalosporin, carbapenems, okay, fluoroquinolone, or other like tetracycline group of antibiotics. So it is very likely this is one CRE organism. CRE means carbapenem resistant organism. So if I come to the carbapenem resistance, so when will you call carbapenem resistance? So carbapenem resistance is by definition if there is a single resistance to either one of the carbapenem. It may be meropenem or imipenem or artapenem. Ideally, by definition, it is carbapenem resistance. Again, a small catch is there. There is certain organism they are inherently resistant to the imipenem. So for that type of the organisms, okay. So then like your Proteus or I think Providencia, this type of organism, they are inherently imipenem resistant, but they are sensitive to the meropenem. So for that particular organism, there should be either meropenem or artapenem resistance should be there. Okay, then so in if I simplify, any one carbapenem resistance means that group of the carbapenem, these are basically carbapenem resistant organism, first thing. So, and then that small thing what I told that you can forget for the those who are beginners, then from that set, you should right now come to know whether this organism is carbapenemase producer or not. There are tests available. So this test is available in two ways. So there are genetic testing or defined type of the rapid testing. Okay, rapid testing methods are there. So they look at the defined type of the antigenic preparation. Okay, so antigenic makeup. So from that makeup, you can come to know whether that carbapenemase producing gene is there or not. That you can do, or there is a method that inactivation of the carbapenem. Okay, there is a method by which there is hydrolyzation or inactivation of the carbapenem antibiotics by technically it is one test where you are looking in the laboratory whether that particular solution, if you add this organism, so there will be carbapenem will be hydrolyzed. So in if I simplify that, so if that is there, so then either way it is a rapid testing you can go, or you can go by this conventional testing by hydrolyzing test. So with that, you can come to know this is a carbapenemase producer. Once it is carbapenemase producer, so then there is the antibiotic choice, okay, will be limited. Limited means you should not use any one of the carbapenems. So then what are the choice? The choice will be defined here, like your ceftazidime avibactam is right now available in our country. That may be one of the choice. Then ceftazidime avibactam, in some cases you may add aztreonam, as we are discussing, or there may be alternate choice. Okay, alternate choice means there may be your these are not available. These are basically beta-lactam. Beta-lactam is newer beta-lactam is inhibitor like verobactam with meropenem or relibactam with imipenem celestine. Other than that, there are those are not again available. That is cefoteracol. Okay, so that is not available. So other than that, there are TG-cycline also that sometimes may work. And then you will also see, like your last slide, there is a colistin or polymyxin B. So Sandeep, should I discuss that point also gradually?
Yeah, sir. Actually, I want to know, like nowadays they don't report sensitive to colistins.
Exactly.
As per the new CLSI guidelines. So,
Exactly.
so when it reports, it is intermediate to colistin. How do you interpret this report?
So right now the modern problem is with the CLSI right now. Actually, we ourselves are not sure about what will be the MIC breakpoint and about the pharmacokinetic dynamics in spite of the very old molecule. they are so defined or unequal that it is very difficult to create any set scientific standard for the CLI by CLSI for the MIC as well as breakpoint. So that's why what they sometimes say, whether you will keep 1, 2, or 3, okay? So not only that, the site of the infection, organism, as well as the patient-specific host factor. So these are the important aspects. So that's why they don't report it as okay, as the CLSI, MIC or any standard. What they normally it should be they left it on the individual laboratory as well as they left it to set their individual country specific any kind of the guidelines. So they will not, from now onwards they will not tell they don't discourage any kind of reporting like MIC or because again, if you are doing a test, most of our laboratory used to do the actually test by the method, DISC method. But ideally for the colistin and your polymyxin B, it should be micro dilution technique. Okay, and that facility may not be available in each and every laboratory. Then that's why technically it may be very difficult. Just keep it this thing that colistin and your polymyxin B, the MIC is very difficult to standardize. Okay, so that's why they don't. And if it is intermediate or ideally most of the cases they don't encourage to use the polymyxin or the colistin, except there are situations for the Enterobacteriaceae infection in the previous case scenario. Okay, and even the colistin is intermediate, you should not use that one. Okay. So because of the different reasons, one is in spite of the intermediate, it may not work. Second thing, what will be the ideal? The loading dose, then the maintenance dose, again a problem. And last one is very kind of this nephrotoxicity as well as neurotoxicity is very high. Because if you are using a very higher dose, that can happen. So that's why in spite of the intermediate sensitive to the colistin, we don't use. But there are only situations where we may use is uncomplicated urinary tract infection, then you may use the colistin, okay, because colistin concentration in urine is very high, okay, and it is renally excreted. So that's why in that scenario you may use.
So
if
one
I,
of the yes, Sandeep, please.
So if I have to answer this question, because we have placed a question in front of everyone that this Klebsiella is there, and this is the sensitivity pattern that we are getting. Now, if I am treating this patient, what are the options that I have? And what are the next few steps that I need to do to choose my antibiotic? Because this is going to be a definitive treatment because I have a sensitivity pattern.
Yes.
So what would be the best way to, further diagnose and further evaluate this patient, and what would be the best option available, and what are the rest option available? So for if I may answer this. So if this patient is showing us carbapenem resistance, what I'm going to do is probably is going to get the kind of carbapenem resistance that this bug is showing. If it is highly if the resistance is majority because of carbapenemase production, then I'll go and do some tests further to find out the molecular tests to find out the kind of carbapenemase that it is producing. Saurabh, can you show us the slide where we are classifying the beta-lactamases?
Okay. Can you see now?
Yes. So this is called Ambler classification of beta-lactamases. If you see, there are serine type and metallo-beta-lactam type classification. So this is purely CRE, which is class A, class B, and class D. So if you have something which is class A and class D type of carbapenemase production, which is say KPC or OXA type, then you can use purely ceftazidime avibactam, which is your first choice, or cefiderocol, which is not available, which is the second choice. If you have a production of metallo-beta-lactamases, then the current guidelines say that you obviously do a synergy test. And if you have a metallo-beta-lactamase production, which is type B, you use ceftazidime avibactam in doses of 2.5 gram 8 hourly in infusion over 3 to 4 hours, along with estrinem in dose of 2 grams 6 hours to 8 hourly. So that is the combination you should do. But to know what is available, you have to do a molecular test. So you have to find out in your area what are the tests which are available to find it. So in my area, I have Carba-R test, which is a rectal swab test. If I get a Carbapenem resistant bug in my patient, I immediately order for a Carbapenem A's identifying test, which is Carba-R, which is available to me, which comes to me in say a few hours, 8 hours, 6 hours, and then you can choose your antibiotic, or you can start everything and then de-escalate. Second choice would be, so the current guidelines say that your use of aminoglycoside and polymyxin, which we were using previously, is not the optimal drug to use in these kind of patients because of fear of nephrotoxicity and inferiority as compared to ceftazidime avibactam. So, or meropenem relibactam, or meropenem pegorvectam, or imipenem this thing, but that is not available with us. Another choice is cefodericol, which is again not available yet. So you are left with these choices. Other choices include cyclins, which is tigecycline. So tigecycline you can use in high doses, which is 200 milligram stat and mg BD, except in UTI and bloodstream infection.
Dr. Sandeep, the question will be again regarding treatment, no? It will be there. So again comes the one the question, next question, no? This treatment. Okay, like if we can further elaborate the what does it mean by intermediate? Is the question still remains like intermediate does not mean it is a resistance, only that they have stopped giving a sensitive pattern. Either now cholesterol is intermediate, we can all practical purpose. I think we can take it as sensitive, right, sir? What do you think?
Basically, the cholesterol and polymyxin be on the basis of this testing means intermediate, or sometimes here we should not use. If we have other choice, as Sandeep was mentioning, that other choice means basically ceftazidime, avibactam, aztreonam, or cyclin, that should be used as the first line of therapy. Okay, for the your enterobacter issue we are discussing about. Okay, so in that scenario we should use, but definitely for that TG cycline bloodstream infection, urinary infection, the concentration is very less. That's why it is not a preferable agent. Okay.
Sir, IDSA still they recommend to use polymyxin is one of the component in the bloodstream infection or soft tissue infection by Acinetobacter baumannii. In that scenario, if the culture reports showed that it is intermediate, can we consider it sensitive?
In that case, actually, intermediate for the Acinetobacter baumannii. Okay, so in that case, you may use, but not as a single agent. Okay,
right. Correct.
That is the most important thing, because Acinetobacter baumannii, if you discuss about that, it is a very difficult organism. First thing. Second thing, the first question comes whether we need to treat the Acinetobacter baumannii or not. The common infection that we normally see, as Dr. Saurabh was mentioning, about the pulmonary or lung infection and the soft tissue, or sometimes the general tissue infection. Okay, so these are the common site, and in those sites, the preferred agent is definitely polymyxin B in comparison to the cholesterol, plus a second choice, second antibiotics. Because single agent may not be sufficient. Okay, so that's why it is important. And if there is a resistance to the carbapenem, means basically for Acinetobacter it is resistant to multiple drugs. In spite of the in vitro testing is showing that this is sensitive, but don't take that as right, because in vitro sensitivity with carbapenem resistance means it is actually resistant to most of the other antibiotics, except relevant antibiotics. Like that relevant antibiotics, we should also know what are the probable antibiotics we are looking for. Because if we just see there is a sensitivity, sometimes you will see even cotimazole. It does not mean that you can treat it with cotimazole. So that means basically, as Saurabh mentioned, that polymyxin B is one component for the Acinetobacter. There are other your ampicillin, sulbactam, or sometimes there may be the artemisinin or tetracycline group, the minocycline. Okay, these are the some drugs that should be maybe chosen from, but definitely there should be 2 antibiotics class that should be added for the tissue infection. Okay.
So, sir, in this case, if we ask how will you treat the patient, what antibiotic will you give in the patient with this culture report? Dr. Sandeep has already like elaborated. Do you want to agree or do you want to add something more with him?
No, because it is acid. You're not yeah. This case is basically we started with the Klebsiella pneumonia. Okay,
Yes.
that is an intermediate to the cholesterol. We should not use the cholesterol in spite of the sensitivity to the cholesterol. Okay,
Yes.
so in that case, what are the choice? Choice means, as Sandeep mentioned, ideally you should go for the testing. Means basically carbapenem producer is there or not. First thing, so you can go by testing Carba or any other testing method, whatever you are following. Along with that, so you should also try to find out what particular phenotypic variance is there. Okay, phenotype, what particular genotypic variance is there. Means basically that AMLA chart, what was you started with that, means basically whether these are OXA producing or not, whether there is a metallo-beta-lactam or not, that is important. And in this juncture, I will also advise you to go through the history of the patient. If the patient had a history in the last 1 year of using this group of drug, means basically ceftazidime, avibactam with combination, or there was a history of within 1 year, any surveillance culture, there was a metallo-beta-lactam is producing organisms, or patient had a definite infection with the metallo-beta-lactam, then you can take it that this patient is having a metallo-beta-lactam, basically carbapenem resistant, okay, organism with metallo-beta-lactam producer. So that's why you should go to the antibiotics like ceftazidime, avibactam plus aztreonam, not only the ceftazidime and avibactam, because only with that there may be failure. And during the time for the Klebsiella, if you have your facility for the synergy test, you may go. But for the E. coli, it definitely you should go for the synergy testing. Okay.
Sir, one of the barrier of using in my institute of using ceftazidime avibactam that we don't do testing for ceftazidime avibactam, and also we don't do synergistic testing. So how often in your institute? The question is for Sandeep also. How often you do synergistic test and you do testing for ceftazidime avibactam in your institute?
Ceftazidime, avibactam, that synergy test would not routinely that we give a request for them and then they only start that testing. So usually I get testing report. Once I get the final report, then I request them to do that test. Only after 3 to 4 days they give that report. And by that time we give our empirical choice. Okay, empirical choice means as we are discussing that ceftazidime, avibactam plus aztreonam dose already Dr. Sandeep mentioned about that dose. There is no point of compromising the dose that should be used.
And sir, do you do testing regularly for ceftazidime avibactam for the receptor? Do you do test regularly? Not synergistic.
Ceftazidime, avibactam regularly we are doing, but if you ask about your aztreonam, so they prepare it differently because ready means basically commercially it is not available like other things. So that's why there is a difficulty. Okay,
and
so
if the culture report initially, if it shows sensitive to ceftazidime avibactam, then still we should go for synergistic or we should not go for synergistic?
no, if it is sensitive to the EA, so you may not go for that one. But again, if the history means basically what I told you, that history was suggesting that it is a beta-lactamase inhibitor. Okay, so whether you are doing synergy or not, but you must use plus aztreonam.
Okay. So next question will be asked by Sandeep. Just share the screen. Sir, this is your slide.
This was when carbapenem testing results are either not available or not or negative. Okay, so this is for the non-urinary tract infection. I said right now I have here in the IDSA the present guidelines. You will see there is urinary tract infection and non-urinary tract. So I am coming to that here. Why it is important? Because the urinary tract infection is defined from the non-urinary tract because of there are defined reasons. So in spite of the carbapenem producers, if your sensitivity test report in the urine infection is showing it is sensitive to say cotrimoxazole or sometimes the levofloxacillin or that quinolone group of the antibiotics, then and patient is not very badly sick. So in that case, even for the pyelonephritis or your catheter-associated urinary tract infection, you may use if that is sensitive. But for the other non-urinary tract infection, okay, so then you should you cannot take those antibiotics as your choice. Okay, that is important. So this what I have here, when carbapenem testing results are either not available or negative, then you should take it as okay. Then you can use either ceftazidime, avibactam, or the meropenem or the verobactam that we are discussing. Those may be used. But for the patient with CRE infection who within the previous 12 months have received medical care in countries with high your prevalence of the metallo-beta-lactamase producing organism, or patient had any surveillance culture that was showing the metallo-beta-lactamase organism, then your choice should be actually ceftazidime, avibactam plus aztreonam.
So the choice of drug will be guided by multiple factors. One is probably your surveillance culture, your probabilities of having a metallo-beta organism, severity of the illness, and maybe the site of infection.
Absolutely.
Okay.
And maybe if you are in doubt, start with all you have, all the armaments, and then you can de-escalate with your further testing. That will be safer for the patient.
Okay. So now another problem is that DTR Pseudomonas aeruginosa. DTR aeruginosa is defined as it non-susceptibility to all of the following, like piperacin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem, cilastatin, ciprofloxacin, and levofloxacin. So do you give any like how should we treat MDR or DTR Pseudomonas? It is same with Klebsiella or like it's a bit different?
Actually, the Pseudomonas, first thing, the resistance pattern it is little defined from the Enterobacteriaceae. Okay, and as we know that the Pseudomonas sometimes, okay, so from the very medical, the third year or the fourth year from the pharmacology, you will see that Pseudomonas infection. There are different kind of myths. First thing is Pseudomonas infection is one of the resistant infection. Second thing is for Pseudomonas infection, you cannot give only one antibiotics. Ideally, you should give 2 antibiotics like that. And that too, more true that if there is a resistance, then more true that you should give 2 and if there is drug resistance, you must add another 2 drugs for the Pseudomonas infection. But those myths are basically, those are past. Right now, we are facing more problem with the Enterobacteriaceae. Pseudomonas is relatively less, and whatever antibiotics we are giving, single antibiotics is also sufficient. Okay, there is no, even for the multi-drug resistant or drug, basically the drug DTR, drug resistant, your Pseudomonas also, even single antibiotics may be here. So question is which particular drug you can use. Okay, so again for the similar type, that the antibiotic sensitivity is of utmost important. Second thing, like your Enterobacteriaceae, so much of the beta-lactamases or the carbapenemase producer, the Pseudomonas is relatively less in carbapenemase producers because only 15 to 20% cases they may produce carbapenemase. And extensive beta-lactamase inhibitors, okay, sorry, beta-lactamase producers or metallo-beta-lactamases are not so much problem with the Pseudomonas. Okay, so that's why usually if your this carbapenem sensitivity is there or not in the Pseudomonas, that you should check. And if the carbapenem sensitivity is there, then you can choose. But if the carbapenem resistant, so then what are the choice? Then the choice is basically you can give. You may find that the carbapenem is resistant to the Pseudomonas, but other antibiotics like your ceftazidime, avibactam, or sometimes the cefepime, or even the piperacillin tazobactam, those may be sensitive to the Pseudomonas. So in those cases, you can use those drugs, okay, for the Pseudomonas infection. But if again with those cephalosporin or penicillins are resistant, then you have a limited choice. Okay, limited choice means you can use either this your cefodiracol, which is not available, or actually in my country right now the other antibiotics choice, there is very limited choice basically. Okay, so that's why in that case it will be very difficult if there is resistance to the multiple here. So obviously the choice, if you go by the guidelines IPSA or EA, so then the polystyrene or polymyxin B may not be encouraged, but there we don't have any choice, so we have to choose from that group. And definitely the your aminoglycoside like amikacin or tobramycin, these may be then you have to choose for treatment, because that time the dose would be little higher. But those are the some cases where if they are sensitive to this or your aminoglycoside, you may use aminoglycosides.
Professor Sandeep, want to add anything?
I think yes. So DTR Pseudomonas are very difficult, very less choices. I think aminoglycosides and polymyxins are something that we are left with. Cefiderocol is something which is promising. Whenever it comes, it should help. Rest of the drugs we have already enumerated. I don't think we have too many choices here.
Only one thing I want to just highlight. In some cases, you will find that there is a sensitivity to fosfomycin or something. It may be reported, but please don't use the fosfomycin for the treatment of Pseudomonas, because it is inherently resistant to the fosfomycin because of the FOS-A gene. Okay, so that's why we should not use the fosfomycin for your Pseudomonas infection. Okay.
Fosfomycin is only for E. coli.
Only for
Right, sir?
E. coli, or sometimes you may use in some Klebsiella, but better for the Pseudomonas, absolutely not.
Fosagin. So coming to the next organism, this is the Acinetobacter baumannii. So, sir, we have already discussed a little bit about how to treat Acinetobacter baumannii. So usually, how do you, what is your preferred antibiotic for Acinetobacter baumannii causing pneumonia?
Okay. Acinetobacter baumannii, basically this is again problem with the first you start with this whether colonization is there or not, or
Yes.
whether you want to treat. If there is no colonization or not that there is definite infection, then what are the treatment options? Okay, treatment options. Amongst all these, there is basically the sulbactam is very potent molecule against actually Acinetobacter. So that's why the sulbactam we choose as one of the drug. And sulbactam individually as single agent should not be used because it does not work much. So that's why ideally you can use the ampicillin sulbactam as combination, and dose will be relatively very higher dose. So those higher dose means sulbactam dose per day will come around 6 to 9 gram per day in divided doses. So if we add with the ampicillin and sulbactam combination, that time the dose may be around 27 gram of the ampicillin sulbactam combination. You can use as either 6 hourly or either 8 hourly or 4 hourly doses schedule. Okay, and some prefer to give it over as infusion over 1 to 2 hours. Okay, that is one option. And again, some people, some recommendations from IDSA, they sometimes use that, okay, it may also be added with other drugs. So that is not very clear from their guidelines also. And what are the other options? Other options means basically there is role for the your definite tetracycline preparation, okay, or a bit of your tigecycline and minocycline, that is the drug that may be used, but again not as single drug. Okay. So not as single drug means basically the tigecycline may be added with the ampicillin sulbactam, or tigecycline may be added with other drugs like polymyxin B also. But again, because of the side effects and it is your choice. And in this context, what I want to basically about the minocycline, if we look at the minocycline and tigecycline, if you are using tigecycline in a higher dose, there is a chance of success. The previous report, there was a high, relatively less high mortality in the tetracycline group. That time dose was 100 milligram followed by 50 milligram 2 times a day. But right now the recommendations with 200 milligram followed by 100 milligram 2 times a day, that negative effect or impact is not there. So that's why you may use with other one agent. Okay. And about the minocycline, again, the dose of the minocycline varying very relatively higher dose. Some means in the recommendations of study, there is 700 milligram of the minocycline first bolus followed by 350 milligram 2 times a day. It is quite high, but as far as the idea says, they usually recommend 200 milligram 2 times a day dosing. And both of them may cause nausea, vomiting, all these things. And for the your what I can say about the sometimes your aminoglycoside. Aminoglycoside is not very preferred drug for the your crab or the drug resistant carbapenem resistant acid bowmani. Okay, that's why it is, in spite of the sensitivity, sometimes it is not a very preferable drug. Okay, and about one thing just I want to highlight that in sometimes in vitro testing of the ampicillin and sulbactam may be showing that it is resistant, but in spite of that, if you are using with a higher dose, you may basically get it may be used, okay, in spite of the in vitro testing, because the in vivo it may be sensitive. And
yes,
anything you want to and
no,
about
sir.
the
Yeah, actually, I had a query. Like, already clarified that we can still use ampicillin sulbactam if ampicillin is showing resistance. Sir, my second question is, like, out of this, we have like now the minocycline and tetracycline. What should I use, like minocycline or tetracycline?
So because of the better data as well as the more uses here, the tigecycline is the first preference. Okay. And then followed by the minocycline. Okay. So that is what is the recommendations is telling. And also we are using the tigecycline, as Sandeep also must agree that it is tigecycline. We have a long experience using with the acinator, but only problem earlier we used to give a lower dose, but right now there is clear indication that the dose would be for the your pulmonary infection. The dose would be a bit higher, 200 milligram stat followed by 100 milligram 2 times a day.
And these are always with combination, right, sir?
Always with combination, not a
And
single.
what is the other like drug is combined? Polymyxin?
You may use the polymyxin B, okay. So that is one choice, or sometimes you may directly use with the ampicillin sulbactam also, or if you are getting the sulbactam is also available, so you can also use sulbactam plus this your tigecycline, okay.
So,
Yes.
so
Yes, Sandeep, please.
the summary here is that sulbactam is one drug that you have to use in all the crabs, irrespective of activities. And the dose is high, which is 6 to 9 grams of sulbactam per day. And you have to add some other to it, which may be tigecycline, which may be polymyxins, or which may be aminocycline. Correct? Second question be that why do I need to add ampicillin? Does it work? Because as far as I remember, sulbactam was available. I mean, giving because of a combination of ampicillin and sulbactam, I have to give ampicillin in very high doses. I mean, 27 grams per day is something that we have not used as such. So why ampicillin and sulbactam? Does ampicillin also have some role in it, or we can use plain sulbactam also? Second question would be, there was a lot of enthusiasm and a practice which still so many people may be using it. That is why I'm question. So there was a trend toward using carbapenem plus polymyxins. So if there was a resistance to carbapenems, we used to use polymyxins, thinking at that point that it was a synergistic effect and it will work. So can you please shed some light on these two questions?
So in principle, we started with that for the acinator of bowmani, we should not use as a single agent, okay, single agent, because of the high chance of that failure. So that's why once we are using only the sulbactam molecule, there is a high chance of failure. So that's why the ampicillin sulbactam molecule as combination is suggested, because ampicillin itself is effective against the Acinetobacter. Okay. So as I have already mentioned, you may find that the in vitro testing, the ampicillin and the or the sulbactam may be resistant, but once you are using in a relatively higher dose, okay, in vivo, it may be sensitive, as well as you may have a successful therapeutic result as a consequence. So that's why the combination of ampicillin sulbactam is one of the
So we have Dr. Sakti Singh. He is our HOD in microbiology. He wants to say something. Oh, his comment will be very valuable. Dr. Sakti Singh, please go ahead.
Hi, one second.
Yes, doctor. Yeah, I can hear you. Sure.
Yeah. So actually, I'm Dr. Shakti Jain. I'm the microbiologist in Shalimar Bagh Hospital, Max Shalimar Bagh. So actually, I was listening. I missed starting 10 minutes actually. But first of all, for the TG cycline in Acinetobacter, CLSI doesn't give any breakpoint for the TG cycline in Acinetobacter. So we cannot report TG cycline in Acinetobacter, and in the Pseudomonas also.
Okay.
Second point is that in Acinetobacter, we don't report ampicillin because ampicillin either it is hereditary, if it is in vitro sensitive, it has to be report resistant always, and we don't have the breakpoint for the ampicillin. Ampicillin we can use, we can give the report. Third question is that third point is that cholesterol for the intermediate. Saurabh, Dr. Saurabh asked that we should consider cholesterol in if we report intermediate sensitivity, then we should consider it as sensitive. No, we cannot consider it as a sensitive because as per CLSI, we don't have breakpoint for the cholesterol as sensitive now. Actually, last I think in 21 or 2021, they omitted the reporting of the cholesterol. They prohibited the reporting of the cholesterol actually, because according to CLSI, only broth micro dilution method we can report the cholesterol. But I think because of some company pressure from bioMario or some Bacti Alert, BD, because as per the CLSI recommendation, we could not. It was not possible to report the cholesterol just on the basis of the dilution MIC based method via the bioMario or Vitec basically. So they have allowed us to report cholesterol as intermediate, not sensitive. And just one of my query is that if it is carbapenem resistant, that if we are reporting the sensitivity, if we are reporting meropenem, imipenem, and ertapenem resistant in our any bug like Klebsiella or Acinetobacter, mainly in CRE patients, we should not wait for the CRE carbapenem is producing any test like molecular or rapid CAR test. We should start avibactam, ceftazidime avibactam plus estunam combination. We should not wait for the test, definitely. And I think in Indian scenario, because the confirmatory test for carbapenem is producing organism is very costly and it takes time, and in every lab it is not available. In Max it is available definitely, but we should not do in every case for the testing of carbapenem is producing test like molecular or rapid. Yeah. Yes, that's it.
Thank you, Dr. Sakti.
Thank you for your.
Yes. Yes.
So I would just add to it that I think the molecular tests and phenotyping and genotyping of the carbapenemase production, I think it is becoming more and more important. And the IDSA encourages to do it. So gradually, it is going to be more and more available because we have very high prevalences of all these kind of organisms. And as of now, ceftazidime avibactam is the only thing that we are left with in treating all these kind of agents. bugs. And I think soon we are going to see the resistance to this also. So probably empirical therapy with this is okay. But if I have a definitive thing in my hand, if I can de-escalate, the cost factor would go also. So I think availability and understanding about all these difficult to treat infection is more important. And I think gradually it will improve.
Yeah,
So-
yeah, sure.
Actually, I read the sales statement regarding that polymyxin for giving intermediate. They said like it is difficult to attain MIC level in the lung. They said it is difficult to attain MIC level without frying the kidneys, and they left on the clinician whether to use it or not, the polymyxin or like colistin. So in that way, like if we consider it is resistant, then we cannot use, but we need to use in many situations. In that case, whether we should take it as a sensitive or is it resistant? Like that was my
No. You cannot take it as a sensitive or resistant, Dr. Saurabh. It is intermediate, definitely, and you have to give the dose as intermediate sensitive. You need to give highest dose basically actually, to achieve the MIC.
so usually we use like 7.5 million in it twice daily dose for polymyxin. So do we need to increase the dose?
Is it highest?
Like usually, I think 7.5 million is standard dose of polymyxin twice daily.
Yeah.
Do we need to
Then-
increase the dose?
We are already
Then
using
you can give.
Sorry?
Then you can give.
anyways.
If you don't have any other option available, any other antibiotic available, and if you get the report like cholesterol intermediate, then you can give the highest dose. Definitely.
Okay. So, sir, another question is that for Dr. Sauren Panja. Earlier, we used to use inhalational colistin for Acinetobacter baumannii. So, what is the current evidence of using this inhalational and like colistin for Acinetobacter baumannii?
Colistin for
Inhalational along with polymyxin IV plus inhalational colistin.
or nebulization.
Like
Actually,
nebulization.
if we go by the nebulization is practically there is no benefit of using the nebulization. There are certain drawbacks also because the latest report means they define kind of the observational studies as well as some of the limited number of the case series. So they did not find any extra benefit using the colistin or any nebulized means in critical care area. Nebulized polymyxin B or colistin, there is no added benefit. And there are certain drawbacks in terms of the nebulization drug delivery is very. Next one is there may be certain bronchoconstriction that is also sometimes earlier we used to give sometimes nebulization, and before that we used to give the salbutamol nebulization to prevent that. So that is also sometimes a problem. So because of that, if there is no benefit, second, you are basically disconnecting sometimes the ventilator, and third, there is a chance of bronchoconstriction. And considering all these drawbacks, are nebulized, and it has no advantage. So unnecessarily, we are putting basically a lever on that without any. So it is better not to use the nebulized antibiotics. And IDSA, the present guidelines, they don't support it. And also, if we go retrospectively go by our practice, almost 8 to 10 years, we stopped giving the nebulization. Means almost 2014-15. Okay, once we received that there is no added benefit, we stopped using the nebulization by for colistin.
So the data doesn't support using nebulized antibiotics, any nebulized antibiotic. Although there are few problems with that also, because most of the nebulized form of antibiotic that we are using is not designed for nebulization. It is for intravenous. So probably there are issues with the formulation also. Second is most of the people are using jet nebulization, which does not produce very small particles, fine enough particles to reach the alveoli. Some studies have done it. There is no definitive. So as far as I've read, there was a reduction in the bacterial burden, but that did not turn into a clinically significant beneficial effect. So as of now, the recommendations are not to use nebulized cholesterol or any other, right, sir?
Yeah, you are absolutely right. And not only that, even for the prophylactically, there will be certain concern. Means some proponents, they used to say, okay, if you give nebulization, means you are preventing the colonization also. Okay, and second thing, colonization may prevent later on the pneumonia or any kind of that tracheobronchitis also is a concern. But again, the as opponent to the theory is that if you are giving a little dose in that area, so and your delivery is not looking at the scientifically what is the MIC in that area, what is the delivery, and certain organism is bound to happen that there will be resistance also. So temporarily for a couple of days you may get some benefit, but later once you are continuously using it, so there is always a potential to have some resistant, drug resistant organisms also. So you are not basically there is no escape from that side also. So it is better not to use the nebulized form of the therapy or cholesterol nebulization.
Can you
Sir,
also
do you
shed some
use
light common practice, which is still going on, I guess, of using meropenem and polymyxin for treatment of crabs?
Meropenem and
Meropenem and polymyxin, which is a common practice. We also used to do a few years back. So it is still
Okay. As far as the latest the guidelines, basically earlier the concern was if we are giving 2 antibiotics and meropenem in a higher dose, may benefit basically overcome this type of the problem with the carbapenem crab or carbapenem resistant acidotic bovine. But there is the data are not available, so that's why the IDS, the present guidelines, they are not encouraging that type of combination. So they are against that recommendations for the high dose of the meropenem and polymyxin B.
Sir, do you use double antibody sometime? Like one carbapenem to sacrifice, and in hope that other carbapenem would work.
One carbapenem?
Like double carbapenem.
dual carbapenem.
For dual
carbapenem.
carbapenem. So dual carbapenem, I don't have much idea about the dual carbapenems.
So Sandeep, do you use?
I had read about it. I've not used it. Definitely not used, but I had read about it, about some specific use where one was acting as a scapegoat, and another one was
so that the sacrificing agent will use up all the carbapenems, and mainly I think artavenom is used as a sacrificing carbapenem, and the meropenem or apenem will actually act on the organism.
That is the idea with
but not lots of evidences. So we are at the end of the session. I would like to have some questions from audience. We have many audiences, many young audiences are here. We're happy to take questions. You can type your questions here if you want.
Do you have any questions?
Actually, I was just going through this paper. This paper was published in the Journal of Antibiotics. Very recent paper. I didn't get the full text. Just from the abstract, they tried to compare different combination against Acinetobacter baumannii, and they found that most efficacious was Ceftriaxone infectum along with polymyxin. Out of this, Eminent, Melibectum, or Meropenem Hevectum. Just wanted to share this. I still need to get the full text of this. If there is no question, can you again, Dr. Sandeep or Dr. Sauren, can you have your final comment, please?
I think again we come back to the same things. I think antimicrobial stewardship is important. Finding the drug-resistant organisms put the patient under a lot of risk of mortality and obviously a lot of cost. But I think right now the need of R is specific testing, identifying the bacteria as soon as possible, for which molecular testing and your phenotypic and genotypic testing is very, very important. So PCR based and different kind of molecular testing is very, very important in very sick patients. And I think IDSA has, those who are listening to us, IDSA has published a very beautiful paper, which is AMR guidance. So go through it and you will gain a lot of information about it. I think all the tertiary care hospitals are struggling with these kind of bacteria, and it should give you a very good guidance about how to treat that rationally.
We have a question from Dr. Vikas. He's asking what should be the dose of meropenem in ICU? Is it 1 gram TDS or is it 2 gram TDS? Hello?
Yeah.
We have a question from Dr. Vikas. He is asking what should be the dose of meropenem? Is it 1 gram TDS or it's 2 gram TDS?
So nowadays, the trend is towards using higher doses because MICs are rising gradually. So if you have a patient, say again, it depends on the kind of patient you are having. Some patient who already has had some sort of antibiotics in recent past, sicker patient, you cannot, the patient is not going to give you too much time to do the adjustments. Go with higher doses. So most of the times we are going with 2 gram TDS doses nowadays.
Yes. Sauren sir, can I have your final comment, please?
Is there?
Sir, your final comment.
Oh, I think the most important is that we should be aware of the defined type of the CRE organism, particularly the enterobacterials. And as we have discussed, our antibiotics choice should be very pertinent to the situations, as well as once we are using the perfect dose and timing should be there. And if there is a facility to know about the what type of, whether there is carbapenem as producer or not, that should be tested. And after that, we should go for that line of treatment. And not only that, the suggestions will be we should continue to keep our own data. Without that, whatever we are discussing, this is basically some of the guidelines, definitely a bit different in our country, our scenario. So we should continue to keep. So if possible, feasible, at least we can keep some of the data for sharing us. And I think next time, whenever we will discuss, I think our own experience should also, we should share in this platform so that we can have a better understanding and knowledge considering our patient, our area. Okay. So what could be the choice? Okay. So that's why I will request all of you to keep some of the data for that. Okay. Thank you from my side.
Sir, you would be happy to know that already ISF has started one observational study to see the effect of antibiotic resistance on clinical outcomes. The name of study is IMPRESS study. I was the principal investigator. We have recruiting in patient in 17 centers. And so far we have recruited around 500 patients till now. And hope in 6 months or 7 months we have completed the study. And if I try to summarize, like, so correct me if I'm wrong, so the class of today's class is that today we discuss mainly 4 organisms. One is Escherichia coli, E. coli, Pseudomonas, and Klebsiella. For Klebsiella, E. coli, and Pseudomonas, we can use Ceftriaxone, Ceftriaxone, and Avectam. And because many studies has shows that Ceftriaxone Avectam has better mortality benefit than polymyxin, and another reason is that nowadays we don't get sensitivity report from of polymyxin. And in case of Acinetobacter baumannii, we should use a combination having a polymyxin as component. What other antibiotic we should use in combination? It depends. It can vary. But latest studies showed that we can use the receptor with polymyxin. By saying this, we'll end this session. We'll meet you in another session with another important topic. Thank you, sir. Thank you for joining. Thank you, Sandeep. Thank you, Sauren, sir. Thank you, everyone. Thank you, audience.
Okay, thank you all. Thank you.